Hello. In case you don't know me, my name is Dr. Karmy. I'm a medical doctor and I have been practicing interventional pain management for almost 15 years. Today I just wanted to speak briefly about various treatment options available for chronic pain management. Chronic pain management, unlike acute pain management, is for patients who've had pain for at least 3 to 6 months, and in spite of tissues healing, the pain persists and sometimes even gets worse over time. Pain management is not just handled by physicians. There's a number of other practitioners who can offer a great deal to help patients with chronic pain, including physiotherapists, chiropractors, acupuncturists, and psychologists. However, in this talk, I'm just going to focus on options we can offer as physicians to patients. First of all, I wanted to talk a little bit about one injection-based approach called regenerative medicine. Regenerative medicine is actually an old approach that has been improved more recently. The idea was to try to strengthen the ligaments that are damaged to stimulate healing of those damaged ligaments. And initially, way that physicians tried to do it was called prolotherapy, where they mixed some anesthetic with dextrose and injected it into damaged tendons and ligaments in hopes of promoting healing. Usually the process would have had to be repeated about once a month. Often it would be repeated 3 or 4 times or even longer. And as I said, this approach has been around for quite a long time, 70 to 80 years. It has a lot of research behind it, but like a lot of treatments for pain, the studies are small, and sometimes some studies support the treatments and other studies do not. The more recent development is platelet-rich plasma injections. The goal is the same. You try to stimulate healing, but what you inject is different. With platelet-rich plasma injections, what you do is you take blood from a patient, and of course blood has some chemicals which promote healing, because when you have a cut, the blood rushes to the area, clot forms, and then the healing of the cut begins. Well, in the same way, you can take the blood from the patient, isolate platelets and growth factors together with platelets which stimulate healing, and inject it back into damaged tendons or joints or muscles to try to stimulate the healing process again.
Platelet-rich plasma, or PRP, may be used by your sports and exercise medical physician to treat injuries to tendon, muscle, or joint. To prepare platelet-rich plasma, you will be taken to our preparation room where your physician will explain the apparatus used and the procedure planned. This is a good time to ask any questions you might have. Your doctor will then remove 10 milliliters of venous blood, which is stored in a specially designed blood container. This is placed in the centrifuge and spun at 1500 Gs for 10 minutes, which allows separation of the various blood products. On removal from the centrifuge, the area above the gel contains serum and the activated platelet clusters. The majority of serum is removed so that platelet concentration is increased. The platelets are then resuspended or re-added to the plasma by mixing the solution. All of this procedure is performed in a negative pressure fume chamber to ensure safety. Once the platelets have been re-added to the plasma, a filter is applied and the solution is then withdrawn. This is safely packaged and identified and delivered by your sports physician to the consultant radiologist, who will re-inject the platelet-rich plasma to the area of concern under radiological guidance. A small number of patients will suffer some discomfort following their injection. They are advised to use some ice and simple analgesia. We advise all recipients of platelet-rich plasma to avoid the use of anti-inflammatories for 72 hours before and after the administration of platelet-rich plasma due to the adverse effects of these medicines on platelet function. When your procedure has been completed, you will be advised by one of our physiotherapists on the rehabilitation exercises we wish you to perform to improve the efficacy of your procedure.
So I guess one of the questions would be, when do you choose to use prolotherapy? When do you choose to use PRP? The answer is relatively straightforward. The advantage of prolotherapy is it's older, it's a little bit more established, and it tends to be less expensive. So if financial considerations are important, one may consider starting with prolotherapy, and if the results are not good enough, one can always try PRP. If, on the other hand, financial considerations are not that important, PRP does seem to provide better results. And the reason I say that is because I have been injecting various medications into joints, tendons, ligaments, nerves and muscles for a very, very long time. And I had an opportunity to compare different approaches. What I found was that a lot of patients that had a relatively shorter duration of benefit from traditional nerve blocks, cortisone injections. In some cases, I even went on to try another treatment that I'll talk about in a while, called Botox injections and PRP, and prolotherapy, and I couldn't really get them to the level of pain control and function that they needed. When I would try PRP, they made much more dramatic progress. PRP is a general approach. It's not something that's specific to a particular part of the body. It can be injected into knees, hips, shoulders, backs, necks. The only place where there's really less experience, where I would probably recommend a different kind of treatment, is headaches. There's really very little research on headaches and PRP, and other injections have a lot more research to back those approaches. With PRP, usually there's a couple of recommendations that they have. One is not to take any anti-inflammatory medications for about 2 weeks prior to the injection. Also, they recommend not to have any cortisone injection, also for about 2 weeks prior to the treatment. It doesn't take a long time. It's about 15, 20, 30 minutes. And depending on complexity of the pain and how widespread the pain is, in some cases it may be a single injection, and in other cases it could be a number of injections. Advantage of PRP is that often one visit will suffice, in the sense that unlike cortisone, where the treatment will often wear off in about 3 months or so, if you are somebody that responds to PRP, the benefit can last for a year or even years. The other difference compared to some of the other injections you may be familiar with is how long it takes to work. With a lot of cortisone freezing injections, you will usually get a response within days, maybe a week or two. With PRP, the treatment takes a little bit longer to work, where you often see benefits at a 4-week or even an 8-week mark. So it's not a fantastic treatment for somebody who just developed a very severe flare-up of their pain a week ago, because it does take a long time to settle down. In addition to pain, PRP has been used for a number of other novel applications. PRP is used to stimulate hair regrowth by injecting it into the scalp. It's been used to stimulate skin rejuvenation. There's a procedure called vampire facelift and vampire facial, where it's used to improve the appearance of the skin. There's even injections into penis and vagina called P-shot and O-shot, which is used to increase sensitivity in both areas and possibly reduce bladder incontinence in women. Other treatment I wanted to talk about is Botox injections. Botox is again one of those treatments that has multiple applications in different fields. Most people are familiar with Botox for cosmetic purposes. However, it has been used for pain and certain muscle disorders for 15 to 20 years. The most established use of Botox for pain is for chronic migraine headaches. And by definition, it means headaches that are present at least 15 days in a month. PRP is not necessarily used frequently for headaches. The Botox is the reverse. Botox is used for headaches very often, and it works very well. Normally, it is injected primarily into the forehead, some of the same areas that are injected for cosmetic purposes, but also often injections are made into the temples and neck and shoulder area, especially if the pain is present wider. It takes less time to kick in than PRP. It takes about 2 days to 2 weeks to work. And when it works, the benefits can last anywhere from 3 to 6 months. Usually it does wear off, and then it needs to be repeated again if you want to maintain the benefit. Over time, physicians realized that Botox can be quite useful for other forms of pain, and so currently Botox is used for everything from temporomandibular joint syndrome pain to trigeminal neuralgia to pain related to whiplash, to back pain, to osteoarthritis of knees and shoulders. In other words, like PRP, it's being used in many different areas. In terms of side effects, first of all, with PRP, side effects are essentially nil, because you are injecting something that's isolated from your own blood. So the only risks are risks associated with needle trauma, and of course, as with any kind of injection, there's small chance of infection from the skin tracking into the area you're injecting. With Botox, the precautions are a little bit more stringent because it is a medication. Generally speaking, they don't recommend injecting it in pregnant women, and they also don't recommend injecting it with certain neurological disorders. Overall, the risks with Botox are quite small, as long as one keeps the dose of Botox lower, especially when injecting the neck muscles, because if you inject too much Botox into the neck, you can get some weakness, and it takes quite a long time for that weakness to go away, maybe a month or so. The way that the Botox works is that it blocks transmission of a neurotransmitter called acetylcholine, and it is a relative of botulinum toxin, which of course can cause a food poisoning called botulism. The difference is in the dose. The amount of botulinum toxin that you need to cause botulism is about 1,000 times higher than the dose that is used to treat pain. So chances of getting botulism from Botox treatment are 0. First of all, I wanted to speak about shoulder joint pain. Shoulder joint pain can have many different causes. Sometimes it can come from the shoulder itself. Sometimes it can radiate from muscles around the shoulder or pinched nerves in the neck. And so the treatment will often be in part dependent on the source of the pain. But assuming the pain is coming from the shoulder, there's several problems that you can have. Some people have inflammation of the joint or the tendons, or the rotator cuff, bursa, that are located around the joint. Some people can have various amounts of damage of the rotator cuff. A smaller amount of damage is called tendinosis. If there's more damage, then people often develop a partial tear, and if there's even more damage, it can become a complete tear of the rotator cuff tendon. By the way, these injuries are not always caused by a specific fall or an event. So in older people, they can just develop spontaneously from wear and tear. The other cause for shoulder pain often is arthritis, either of the shoulder joint itself or of acromyoclavicular joint, which is basically the joint between your collarbone and your shoulder blade located right above it. Often hockey players will have separation of the shoulder. Well, it's usually AC joint that's being separated, not the actual shoulder joint itself. The treatment for shoulder is quite variable. People will start with exercises and physiotherapy program. And if they respond well to that approach, that's usually all that they need. If they don't respond to physical modalities, and by that I include acupuncture and mobilizations Physiotherapy is not just a single treatment. They have an array of treatments that they can try. Then the patients will often start thinking about the injections. The most common type of injections that are done around the shoulder are cortisone injections to settle inflammation down. Even in cases where there are tears, often cortisone is injected with good results, because even with tears, often a lot of the pain isn't coming from the tear itself, but from the inflammation associated with the tear. The other treatment, which can be quite helpful and incidentally also covered by OHIP, is nerve blocks. And what you're doing with nerve blocks is you're trying to desensitize the nerve endings which supply the joint by injecting anesthetic into the nerves that go to the joint, and sometimes also injecting anesthetic into muscles around the joint. Unlike cortisone, where usually one treatment is sufficient. If it works, it works. If it doesn't, then probably there's no point in repeating. With nerve blocks, it's usually a gradual approach, where with each treatment, pain gradually becomes less and less until hopefully it disappears. Advantage of nerve blocks is that it's OHIP covered and that the side effects are quite minimal. There is, of course, risk from lidocaine or whatever anesthetic the physician is using, but the risk is no higher than if you go to a dentist and they will numb the tooth before they drill it. Cortisone is a hormone. It has a few more side effects. It can be bad for the bone and the cartilage, and it can sometimes make tears bigger because it can soften the tendons. So because of that, I will usually warn the patients not to engage in intense activity and lift anything heavy for about a week after the treatment. But the advantage with cortisone, of course, is time saving. With cortisone, you do one injection, and if it works, you don't usually see patients for months or sometimes even longer. So if I have a patient who came from very far away and they have difficulty going back and forth, I will tend to go with cortisone. If somebody lives close by, especially if you're not terrified of needles, I will often start with nerve blocks and only proceed to cortisone if they don't respond to nerve blocks. Unfortunately, there's no treatment that all patients respond to, so the more treatments you have, the more likely you will find something that patients benefit from. Next treatment I wanted to discuss is prolotherapy. Prolotherapy, the idea is to try to stimulate healing and regeneration of the damaged rotator cuff tendons. To do that, you inject again freezing, but then you add dextrose to the mixture, and there is some suggestion in the literature that that can stimulate healing. Usually, one has to do this treatment more than once. On average, it's once a month for 3 months. Again, the risks are quite small. Essentially, it's the risk of the needle and the risk of the anesthetic. If you've tried the treatment 3 times and you're still not seeing any progress, it's probably not going to help. The advantage of prolotherapy is that, again, it's fairly safe treatment. It is also less expensive than some of the other injections I'm going to talk about, but it is not covered by OHIP like the cortisone and the nerve blocks. So if you wanted to try something outside of OHIP, prolotherapy is your least expensive option. If prolotherapy doesn't work, another treatment which may be worth trying is Botox injections. Botox is a chemical which blocks transmission of acetylcholine, a neurotransmitter. Initially, it's been used for cosmetic purposes, but it has been used extensively for pain, especially migraine headaches. Botox interferes with transmission from nerves to muscles by blocking transmission of a particular chemical called acetylcholine. Usually the blockage is in effect for about 3 months, and during that time the Botox exerts its effect. There's some things one has to be mindful of when one is injecting Botox. Botox is a very powerful muscle relaxant, to the point that if you inject too much, you can actually paralyze the muscle or weaken it to the point that a person may not be able to change the way that they use their arm, which can in turn cause pain because of changed biomechanics. So unlike freezing, where if you inject too much, it just clears your system within a few hours, with Botox, less is more. Because once you inject it into a given muscle, it's going to stay there for months. So I will usually start by injecting relatively lower doses, and if the patient doesn't respond, one can always increase the doses over time. What to expect with Botox? If it works for shoulders, I find it takes a little bit longer to kick in than for some of the other kinds of pain, usually 2 to 3 weeks to see the effect, and the benefit will usually last anywhere from 2 to 6 months. Botox can be quite expensive. If one has a drug plan that will cover Botox for pain, then I think it is worth a try. If it's not covered, then probably PRP injections, which I'll talk about next, would be a better choice to try. However, if you do have coverage, it is less expensive than PRP. Next treatment option for shoulder pain is platelet-rich plasma injections. It is actually, in terms of intent, quite similar to another treatment I talked about, prolotherapy. What it's trying to do, it's trying to stimulate healing of damaged rotator cuff or damaged joints. Some people say that if you have a complete tear of rotator cuff, PRP will not work. What you are doing with that treatment is you are taking blood from a patient, you spin it, and you isolate the growth factors in the blood that promote healing. When somebody has a cut, you inject it into the damaged joint or around the rotator cuff, and within 4 to 8 weeks the pain starts to subside. The advantage of this treatment over some of the others is that, first of all, it's very safe because you're using your own blood. The other advantage is that often the results last a really long time, unlike cortisone and Botox, where often the effect will last for a certain number of months. With platelet-rich plasma injections, often the benefit can last for years. The only downside to PRP is the cost. It is more expensive than some of the other options, But given that it lasts longer, in the long run, often it is balanced out by increased duration of the benefit. Next treatment, which I'm aware of but really know little about, is injections of stem cells into tendons and joints. Again, the idea is to stimulate healing. From what I understand, it tends to be more expensive than PRP. And since I don't have personal experience with it, I'm not sure whether the results are any better. So that's all the injections. If patients don't respond to injections, then sometimes they will respond to surgical intervention. Most of the time, surgeries will not be done for tendinosis and smaller partial tears, but sometimes surgeries can be beneficial for full thickness tears of the rotator cuff. Also, sometimes surgeries are used in very badly arthritic shoulder joints. They can actually do a shoulder joint replacement. Couple of things to say about surgery. One is that nobody is ever obligated to go for surgery. It is just one more option for treatment of pain, and it only becomes an option if anatomy is sufficiently abnormal that surgery is likely to be beneficial. The bigger the anatomical abnormality, the more likely surgery will help. I have often patients who come to me with very severe pain and relatively small abnormalities on their MRI, and they can't understand why surgeons won't operate on them given how much pain they have. Well, surgery has more risks and side effects than conservative management, and in these kinds of patients, the risks of surgery probably outweigh the benefits. I guess maybe let me digress and talk a little bit about a couple of other points. First of all, a lot of these injections are done by many different practitioners. So how to choose who to go with when you are trying some of those injections? I think it depends a little bit on what kind of problem you have. If you have a very isolated problem in the shoulder and your pain doesn't radiate into the arm, into the neck, into the shoulder blade, and so on, then probably it doesn't really matter that much who you choose. Orthopedic surgeons will often do a great job with cortisone injections or PRP injections. Some of them are starting to get into doing PRP. Some physiatrists will do it, sports medicine doctors will do it, even some family physicians are starting to do certainly cortisone injections. If, however, you have a more complicated case and pain is quite widespread and it involves shoulder blade, neck, etc., then chronic pain physicians who work in pain clinics are often better equipped to handle it, because in those sorts of cases often it's not enough just to reduce the pain in the shoulder joint itself. Often there's a lot of pain originating from some of the nerves and muscles around the area. And pain management physicians are primarily physicians who do injections day in and day out, hundreds of injections a day. And they're quite used to complicated patients who have many different sources of pain, and they are much better at picking which sources of pain are more important to treat and which sources of pain are better left alone. The other brief topic I wanted to discuss is guidance. Over the last 4 or 5 years, ultrasound guidance became big in pain management. Essentially, the idea is instead of the traditional injections where basically you use bony landmarks to figure out where to inject, you are using the ultrasound so that you are able to see the tip of the needle, and you can put the medication closer to the damaged tendon, or more precisely into the joint. There's no question that ultrasound will enable putting the needle closer to your target. What's somewhat controversial is whether or not it will improve outcomes, because generally speaking, when you inject a liquid medication, whether it's PRP or cortisone, it'll spread. And it'll spread a good inch, half an inch to an inch from where the needle is located. So being exactly a millimeter away from the tendon doesn't really give you a better result, or that much better result, than being, say, half a centimeter away. And most of the research bears this out. Been a number of studies comparing ultrasound-guided compared to landmark-guided injections, and while consistently ultrasound-guided injections do better in terms of accuracy, in terms of outcomes, there really isn't a significant difference. But that's the studies. My personal experience with it is that if you have an experienced injector using landmark-based technique compared to somebody who is an inexperienced injector, the difference can be huge, about additional 30% of success, I would say, between somebody who is experienced and who is not experienced. If you throw ultrasound into the mix, it probably does improve the results slightly, and by slightly I mean about 10%. So if I, let's say, treat a patient with cortisone injections, and let's suppose I get 8 weeks of improvement, if I send the same patient to do this under guidance in a hospital, and I've done this little experiment, they might get 9 weeks out of it. So is it worth it? Maybe. Depends on, I guess, your preference. There's often additional fees for using ultrasound guidance. But I think what it definitely does make a big difference is how often the physician has done injections and how experienced they are. So today I just wanted to show what ultrasound guidance looks like, and although I'm not going to inject today, I wanted to use the ultrasound at the clinic just to show what sort of images you can see. So here you can see the collarbone. This is the edge of the edge of the collarbone, and that's what forms the AC joint. And underneath it, there are some muscles that will form rotator cuff farther down. So we're going to go down a little bit farther. See what we can find. Go this way as well. So this is the front. the better picture. And you can see the rotator cuff tendon that inserts onto the humeral head. Here we can go down the arm, and this is the bone, and then this is the muscles above the bone. In this case it would be deltoid muscle. You can see the elbow joint right here. I talked earlier about platelet-rich plasma injections, and as I mentioned, that we take the blood and then we try to separate the growth factors from the blood to inject them into damaged joints and tendons. So what we use to do that is a centrifuge, and I just brought our clinic one here. It's from Harvest. There's a number of different manufacturers of kits that are used for PRP and centrifuges. The one that we picked was one of the more expensive ones, and the reason we did that is because different providers end up preparing different quality of PRP. This particular provider, Harvest, is able to concentrate PRP and growth factors to a high level than a lot of the other providers, and so we decided to go with them. Now I'd like to talk about knee injections. Again, from a perspective of a physician rather than a physiotherapist or a chiropractor who may have a very different perspective on this condition. With knees, there could be many different sources of pain, from tears in the menisci to tears in some of the ligaments, medial collateral ligament, lateral collateral ligament, ACL tears are quite common in athletes, and then of course arthritis. Sometimes pain in the knee can even come from other sources not related to the knee, such as hip or even lower back. There's many useful investigations for knee pain. However, the most sensitive is MRI. X-rays will show broken bones, and ultrasounds will show a little bit of fluid, but really, if you want a detailed picture of the anatomy of the knee, you need an MRI scan. Treatment for knee pain is varied, and most patients will start by trying physiotherapy. And when I talk about physiotherapy, I don't just mean exercises, I mean all the various modalities, from laser to ultrasound to acupuncture to mobilizations and so on. Those who don't respond to those approaches will often end up seeing a medical doctor. So what sort of treatments can medical doctors try? First, the most common one would be cortisone injections, and for certain types of problems that are associated with inflammation, like arthritis, for example, or tendonitis, it can work quite well. There is a small risk of damaging cartilage in the knee. However, if cortisone is not injected more often than once every 3 months, chances of damage to the cartilage is quite small. In terms of duration of benefit, It varies for somebody who just developed pain for the first time. Sometimes you do a cortisone injection and the pain doesn't come back. If you have somebody that had pain for a number of years, usually cortisone will help for about 3 months or so. Another treatment which can be tried is hyaluronic acid injection. Hyaluronic acid is a medication which is supposed to replace the fluid in the knee joint. In other words, it's trying to help lubricate the joint. It's often quite an expensive treatment if you don't have a good drug plan, because the cost of the medication itself is somewhere between $300 and $600. The effectiveness is not very high, at least from my experience. There is an occasional person that responds well, but majority of patients don't respond to this intervention. Having said that, if you have a drug plan, it may be worth a try because the risks are very low. Again, just the risk of the needle itself and trauma from the needle. And I guess with all injections, risk of infection being tracked by the needle into the joint. The next injection that's worth trying is prolotherapy. Prolotherapy is a very old treatment. It has been around for almost 100 years. The idea is to inject into the knee a mix of anesthetic and another medication, most commonly dextrose, which actually causes a little bit of inflammation to try and stimulate repair and strengthening of some of the ligaments and tendons around the knee joint. The downside to this approach is that it's not covered by OHIP, so there's a charge for the injection. Advantages are, again, it's extremely safe. Neither dextrose nor freezing is likely to cause side effects. Of course, anything is possible, but the risk is about the same as getting a tooth frozen when you go to a dentist. Generally speaking, with prolotherapy, one treatment will not be enough unless you are quite lucky. Typical protocol is once a month injections for about 3 months, and it does take a long time to kick in. Often it takes months to see the benefit. Another approach is Botox injections. There have been some small studies where you inject Botox into the knee and have good results with it. Botox is better known for treatment of migraine headaches and wrinkles. However, it can be useful in any number of painful conditions. The risk with Botox is again quite low, but they don't recommend it in patients who are pregnant and with certain neurological disorders. When the Botox works, it can be helpful for 3 to 6 months. Unfortunately, it is very expensive, and so I will often use it on patients who have a drug plan and for whom Botox is covered for pain. If it is not covered, I often will go with another alternative and only circle back to Botox if some of the other alternatives don't help. The next treatment option is PRP, or platelet-rich plasma injections. The idea is, again, to stimulate healing, just like with prolotherapy, but what you inject changes. With prolotherapy, as you remember, it's dextrose combined with freezing. With PRP, what you do is you remove blood from a patient, you spin it in a centrifuge, you isolate the growth factors which stimulate healing in, say, cuts, and you inject it into the knee joint and often around the knee joint. Advantage of this approach is that often a single treatment is enough and the results can last for years. There's also no risk from the medication you are injecting, because essentially it's component of your own blood. Downside is the price. It's usually about $600 for a single knee injection, and because it's not a drug, it's a component of your own blood, usually it would not be covered under a drug plan, even if you have one. You usually see benefits within 4 to 8 weeks, so it does take a while to kick in. And you can't take any anti-inflammatory medications or have cortisone injections within 2 weeks of the PRP shots. There are some cases where surgery is the preferred approach, certainly with a lot of fractures involving the knee joint. Surgery is the way to go. There is strong tendency to do surgeries for patients who sustain ACL tears, although even in those cases often people will start with physiotherapy but then will often progress to surgery. And finally, patients who have very severe arthritis of their knees that's not responding to conservative measures, including injections, often surgery can be a very effective approach. Recovery from surgery can be quite painful and long, and so you have to have a really motivated patient who will cooperate with post-surgical physiotherapy. The other thing to say about knees is it's one of those few joints where weight loss can make a world of difference. For shoulders, for neck, for back, although weight loss may make a little bit of a difference, usually the benefits are very small. But because most of your body is supported by your knees, weight loss can really make a huge difference in how much pain is in the knees and how quickly arthritis in the knees progresses. I'd like to say a few words about fibromyalgia. At my clinic, I see a lot of patients with fibromyalgia. For those of you who are not familiar with the term, usually these patients have very widespread pain where almost their whole body is painful. Often that's not how they start out. Often they start out with a car accident or some injury in one part of the body, and over time the pain spreads to involve larger and larger areas. Nobody really knows why some people develop this sort of widespread pain while others have pain that just stays in the area that was injured and goes away in a few weeks. However, it is not that uncommon. There are some ideas about the causation. Well, first of all, although all the muscles are tender, generally speaking, if you do a biopsy of the muscle, you don't see any anatomical abnormalities, so they don't think it's a muscle disorder. And the best guess at the moment is that what happens with these people is hypersensitization of the nervous system. In other words, It's almost like a memory where somebody develops pain in one area, and then, although perhaps the area has healed, the nerve endings and some of the nerves in the spinal cord and the brain still remember that pain, and they continue to send the pain signals, and over time it spreads to involve bigger and bigger portion of the nervous system responsible for sending pain signals. Often these patients have other problems in addition to just pain. Often their sleep is affected, their mood is affected, their focus and concentration are affected. And because the pain is so widespread, it is quite difficult to treat it with some sort of a surgical intervention. The pain will, generally speaking, last for years. Although there's some debate about it, I suspect it is just an extreme variation of your typical chronic pain patient with whiplash. In other words, what I'm trying to say is that the treatment for fibromyalgia and treatment for chronic pain patients are really indistinguishable. So the diagnosis is often worth making for legal reasons, if one is applying for disability and so on, but it's not, it doesn't necessarily make a difference in terms of how a physician would approach a patient, besides the fact that you wouldn't really think of surgery as your first approach. How are fibromyalgia patients treated? Well, first of all, in terms of some of those other problems I described, problems of focus, problems of concentration, problems of energy level, unfortunately, Western medicine doesn't have any useful approaches. Often these patients also have problems with their sleep, and the hope is that perhaps if one can reduce some of their pain, and perhaps they're going to be able to sleep more, perhaps their energy level and focus and some of the other issues will improve. Often these patients will not respond to a single approach, and often they are treated with multiple approaches, but what these approaches are will vary from patient to patient, because unfortunately, like with most other conditions, different people respond to different treatments, and approaches will vary from just exercise and eating well to some people will try naturopaths, and some people try herbal remedies, people will try physiotherapy approaches, people will often try medications, although unfortunately tablets don't work very well. The advantage of tablets is, of course, that they can cover pain in the whole body, whereas a lot of the other approaches that we use at the clinic do not. And so I will often use medications on patients, realizing that the benefits will be quite small and they may not be able to tolerate a lot of the medications we're trying. My rule of thumb with medications is that there's nothing that you give a patient for pain that they're obligated to take. Everything is just a try. If the benefits outweigh the side effects, I will keep them on those medications, and if the side effects outweigh the benefits, I just stop it. I generally speaking stay away from narcotic medications like OxyContin or Duragesic for patients with fibromyalgia, because first of all, the research doesn't support the use of those medications, and second of all, they are not great medication for long-term use, and fibromyalgia is a long-term condition. So what do I use for patients with fibromyalgia? A lot of patients with fibromyalgia will be treated with trigger point injections and nerve blocks, and what we're trying to do is we're trying to desensitize the hypersensitive nerve endings and therefore reduce the pain. Unfortunately, because it's an injection treatment, it won't cover the whole body, and therefore usually I will focus on one area, usually the area that interferes with function the most. And then if that area starts to respond, we move on to other areas and treat other areas, usually with fibromyalgia, because it's such a difficult condition to treat. The treatments will last for years, and it's usually small gains. Then the other thing that I will frequently use is cortisone injections. I find with fibromyalgia patients, cortisone injections are not very useful if they have very widespread pain. However, sometimes they will have widespread pain, and then all of a sudden the pain in one particular area becomes 10 times worse than it normally is. And often in those cases it's the inflammation that's causing this increase in pain. And so especially if the regular trigger point injections and nerve blocks are not helpful, I will often try cortisone injections, and most of the time within 2 days to 2 weeks the pain will settle down. I will usually warn the patients to reduce the activity for about a week after the injection to avoid damaging the injected joint or tendon. The other approach which I find quite helpful is Botox injections. Botox injections made from botulinum toxin, which in high doses can actually cause botulism, but in low doses, and we're talking doses that are 1,000th of the dose used for that can 1,000th of a dose that can cause botulism, it can be very helpful for any number of conditions, from wrinkles to migraines. The advantage of Botox over nerve blocks is duration. With nerve blocks, often you get days, sometimes weeks of improvement, but generally speaking, for most patients, they're going to have to come back for those injections fairly frequently. With Botox injections, the benefit, if they respond, will last for 3 to 6 months, and so you are able to have much longer periods of improvement. And because, as I mentioned, even with nerve blocks, we can't treat the whole body, if we don't have to worry about some of the areas because the Botox is helping there, we can focus our nerve blocks on the areas that Botox did not cover. So usually I will layer Botox on top of nerve blocks. I will not very often use it instead of nerve blocks in somebody with very widespread pain. Botox is quite expensive, and often it's difficult to get coverage for it for pain. It's often covered for certain neurological disorders, but for pain it's often difficult to get it covered. However, if we're able to get the approval, I will try Botox. I find it's particularly helpful for headaches, and most research to support the use of Botox for pain is for headaches, but it can be quite useful for a number of different areas. The last treatment I wanted to discuss is platelet-rich plasma injections, PRP injections. I've had several fibromyalgia patients that I've been struggling with for years that were getting some improvement from the modalities I've mentioned, but were still very limited by their pain, and so I tried them on PRP. Platelet-rich plasma injections are supposed to stimulate healing. What you do is you take out blood from a patient's vein, you spin it, you remove the growth factors which stimulate healing, and you inject it into damaged tendons and joints in hope of stimulating repair and improving the healing process. In addition to that, I suspect PRP actually reduces pain directly, just because it often takes a very long time for healing to take place, but the benefits from PRP will often be much faster than the period it takes for tissues to heal. What I will often do with these patients, or what I did with patients that responded, was first of all, I picked the areas that did not respond well to other treatments. Second of all, on the basis, because with fibromyalgia, often a lot of muscles, a lot of nerve endings are painful, it's often difficult, if you don't know the patient, to really predict where to inject PRP, because you only have a small amount of it. You have to choose carefully where to inject it. If you inject it into areas which are not the main source of the pain, the results will not be very good. And so in those particular patients, I had the benefit of treating them for a long time and knowing from my trigger point injections, nerve block injections, which areas respond better and which areas respond worse. And so I used the areas that responded better to nerve blocks, and I injected PRP into those areas. And I had really good results that lasted for 6-9 months, and we'll, I guess, have to see how long they go, hopefully years. As I said, as with all chronic pain patients, exercise is really important. If you just reduce pain without combining it with exercise program, often pain at rest will improve, but function will not. And obviously eating well, leading in general healthy lifestyle, because with fibromyalgia, no matter what we do, a certain amount of pain will still be left over. Often it is much easier to focus on attaining specific goals that pain was holding them back from, rather than focusing on totally getting rid of pain. Fibromyalgia can be a very soul-destroying, discouraging illness. And if one focuses on totally getting rid of pain, then one usually doesn't really sense much of a progress, because no matter what we do, certain amount of pain will be left over. So I usually advise my patients not to focus so much on how much pain is left over, but rather to focus on improving their function, trying to get back to doing some of the things that pain was holding them back from doing. This way, it's much easier for them to see progress, to see how far they've come, and get some sort of meaningful improvement in their lives. Hello, my name is Dr. Karmy. For those of you who don't know me, I have been practicing pain management for almost 15 years. Today I wanted to talk briefly about migraine headaches, many different approaches to management of migraine headaches, and there's different types of migraine headaches. Physicians divide them in several different ways. However, I like to think of them in a somewhat simplified way. There's patients with migraine headaches whose pain is limited to the head and whose headaches are intermittent. They may get 1 or 2 migraines a month. And then there's patients with migraine headaches that are constant, that are there almost every day. Often these patients also have pain in other areas like neck and shoulders, and sometimes even back. These two groups behave very differently, and the treatments for them is quite different. The patients who have intermittent rare headaches, often they do best with abortive treatment with medications, things like Imitrex or Maxout or Zoloft can be very effective. These medications are specifically designed to treat migraines. Unfortunately, they're quite expensive, and if you don't have a good drug plan, then they're not covered. With these medications, there are also certain contraindications, including patients who have heart problems or who develop chest pain when they take these medications. The more common medications used for patients whose migraines are perhaps less severe is anti-inflammatories, so over-the-counter Advil. Liquid gels in particular seem to be helpful. Aleve, Tylenol, all of these can be used for an occasional migraine, and different patients respond to different ones, so it's worthwhile trying a few and see which one is helpful. The other triggers for migraines, which perhaps if you change can reduce or prevent migraines, is diet and sleep. Often patients with sleep, either they sleep too much or they sleep less than usual. Any kind of change in their sleep routine will sometimes trigger a migraine. So trying to have regular sleeping habits can be helpful. And then there are certain certain foods that can sometimes trigger migraines. The common ones are chocolate and cheese and red wine. But something to keep in mind is that there's actually dozens of possible triggers, and what's a trigger for one patient may be totally harmless for another patient with migraines. So if one was going to try to avoid certain foods in hopes of helping their migraines, it has to be done on a trial basis with a diary where you try to eliminate one food at a time and see whether or not it helps your migraines. Unfortunately, migraines will also often happen around menstrual period time in women, but then there is really nothing much that one can do about that. Sometimes migraines do improve in menopause. For patients with constant and chronic pain, before maybe I do that, let me talk about physical treatments for migraines. Physical treatments for migraines are not terribly effective. Some patients will respond to acupuncture, and certainly if their pain involves neck and the neck pain is constant and pain in their head is actually originating from the neck, then sometimes a lot of the physical modalities that are used for neck pain, be it chiropractic manipulation or traction or physiotherapy, can be helpful. Patients will also sometimes use some supplements like coenzyme Q10 and magnesium. When it comes to medical doctors, for people with constant chronic pain, usually are started on preventative medications. There's a number of them. One common one is beta blockers, things like atenolol, propranolol. They don't work well in patients who have had the neck and shoulder and back pain, but if pain is isolated to the head, then often beta blockers are helpful. There's another group of medications called calcium channel blockers, which can be helpful too for the same group of patients. Usually it takes for these medications about 2 weeks to a month to work. With beta blockers, patients with asthma, it is contraindicated, and also sometimes it can affect blood pressure or cause depression. Another group of medications which can be helpful for just migraine restricted to the head, but also for people with migraine plus more widespread pain, and medications that are also used for depression or epilepsy. So in these groups, there's medications like Side effects, depending on the medication, can be weight gain, drowsiness, and dizziness. Again, they take about a month to kick in. Another good option, and that doesn't have some of the side effects, are injections. The most common type of injection done for migraines is a Botox injection. In my experience, it doesn't help everybody, but about 50 to, I would say, more like 70% of patients will respond. Botox is medication that's also used for wrinkles, and actually the spots that they use for migraine treatments are almost the same spots that are used for wrinkles. So in addition to having fewer headaches, your forehead will be smoother. The treatment will usually takes 2 days to 2 weeks to kick in, and it lasts for 3 to 6 months, and then usually it needs to be repeated again. Typical dose used is 200 units, and most drug plans will not cover it unless you've tried some of the preventative medications I listed first. If you don't have a drug plan, then a lot of patients will respond to injections with fewer units, which will lead to, I guess, a less expensive treatment. Finally, there are nerve blocks. Nerve blocks can be helpful for migraine headaches, and some patients will get results that can last for weeks or even months. The other nice thing about nerve blocks is that they are covered by OHIP, so there's no charge to the patient. What you're trying to do is usually you're trying to desensitize the nerve endings that go to different parts of the head. Unfortunately, in general, the results are not as long as with Botox, or for a lot of patients, the results will only help for 4 or 5 days rather than 3 to 6 months. And that's really all the options available for patients whose pain is again coming primarily from the neck and radiates to the head. Patients who have constant neck pain rather than neck pain which only occurs when headaches start. Sometimes PRP injections can be helpful. PRP is platelet-rich plasma injections where you're using patient's own blood to inject muscles, joints, and nerves in the neck. And if the pain is coming from the neck, the benefits can last for even longer than Botox, maybe a year or longer. Unfortunately, this treatment is not covered under most insurance plans, and the cost is in the neighborhood of $600 with very minimal side effects. My name is Dr. Karmy. I wanted to briefly talk about hip joint pain. I'm a chronic pain physician. For those of you who don't know me, I've been practicing in the field for almost 15 years. First of all, hip pain does not always arise from the hip. I would say about half the time when I see a patient and they complain of hip pain, the pain is radiating to the hip from their back. So as part of, I guess, decision about how to treat a patient, the first part is to try to figure out where their pain is originating from. If it is really coming from the hip, the most common cause is osteoarthritis, although sometimes it can be due to damage of the cartilage around the hip, or it can be due to inflammation of the bursa on the side of the hip, or sometimes muscle spasm around the hip. In other words, what I'm trying to say is that there's many causes for hip pain, and hip arthritis is certainly not the only one. In terms of treatment, if it's a genuine hip arthritis, weight loss can often be very helpful. Unlike other joints like neck and shoulders, for hip pain, for knee pain, weight loss can make a huge difference in terms of improvement of function and pain reduction. It also prevents further progression of arthritis. Also, for hip pain, physical modalities can be quite helpful, from physiotherapy to acupuncture and so on. In terms of treatments by medical doctors, it kind of depends on the severity of arthritis. Hip joint pain will often respond to injections of freezing, injections of cortisone, especially if the pain is not coming from the joint itself, but rather from trochanteric bursa, which is a lining of the bone on the side of the joint, then cortisone injections can be very helpful. The problem with cortisone is it can cause damage to bone and cartilage, especially when injected into the hip joint. The risks are not big, but if it happens, this damage can be sufficiently severe to require hip replacement surgery. Another treatment option is platelet-rich plasma injections. PRP, the idea behind PRP is you take the blood from a patient, you spin it in a centrifuge, you isolate the growth factors which stimulate healing. Of course, when blood rushes to an area that's injured, that is one of the functions of the blood. And they take these growth factors and they inject it into the hip joint in hopes of stimulating healing of the arthritic joint. It is somewhat controversial whether or not it actually helps the healing process. However, in practice, it can be very effective in reducing pain. Another advantage is that the benefits will often last for a very long time. If cortisone will often last for 3 to 6 months, with PRP injections you can have an improvement which lasts for years. As I said, the more anatomically abnormal the joint is, the less likely the injections will help. And the injections mostly help for pain. They will not help if you have a lot of stiffness in the joint and your biggest problem is not being able to move the joint. If you can't move it because of pain, all kinds of treatments can help. If it's just stiff with relatively little pain, then it's not very likely that any of the injections will be helpful. The last treatment is hip replacement surgery. In my experience, it is one of the most effective treatments for severe hip arthritis. There's other joints that are replaced, knee joints, shoulder joints, but often the benefits are not as great. With hip replacement surgery, the results often are very, very good. Of course, it's a bigger procedure, the recovery is hard, and you have to have a motivated patient. Also, sometimes in patients whose bones are very thin and osteoporotic, the outcomes are not as good because they have to anchor the prosthesis in the bone, and if the bone is very soft, it might become loosened in which case people will end up with bigger problems than they started with. Supplements, some people will try supplements like chondroitin and glucosamine. It's very much hit and miss. I haven't seen a lot of great results. But if there's no downside, so I will recommend if patients wanted to try it for 3 months. If it helps, continue. If it not, move on to something else. Another treatment which can be helpful is Botox injections. Botox is mostly used for other forms of pain, but if you've exhausted those treatments, on occasion injecting Botox into the hip joint or doing another procedure called prolotherapy, where injecting dextrose into the hip joint, can be helpful. But the best bet for hip joint in terms of injections are cortisone and PRP, platelet-rich plasma injections. Thank you. Thank you for listening to me. If you would like to find out more information about any of the treatments offered at the clinic or book an appointment, our website is karmyclinic.com. That's Karmy clinic, all one word, .com. Our phone number is 905-278-5158. We're located in Mississauga, in Port Credit area. Thank you.